So the conversation today and the topic is very timely in a time of uncertainty. We talk about it and you hear about it in the news, and unless you live in a cave somewhere, you have heard what's going on in this country. So the topic is, as Bishop Perry had mentioned, and he summed it very nicely. He talked very eloquently about what is facing the nation today, healthcare disparities. It is a topic that is near and dear to my heart. Because I live in it every day. Talking to every patient of mine, seeing some patients who could not afford their medicine, or some of those who tell me, I couldn't come see you because I cannot afford the co-payment. It's painful to hear that. It is also painful to hear some patients not taking their medicine appropriately and landing in the emergency department because the medicine is so expensive. So something that we talk about, and we always try to find ways to improve, and unfortunately we see that the system is not helping. Sometimes I feel that we're going into the wrong direction. So today we're going to touch on multiple areas that are intertwined in this subject. We're going to talk about the cost of healthcare in the United States. We're going to talk about the global overview. Where do we stand in the world, other civilized nation? And what are the drivers for healthcare cost in this country? Why do we pay so much? Why do we have to spend this much in healthcare where it shouldn't be, and it should be more affordable? Then the disparities in healthcare, what's causing disparities and what's the effect of disparities? And it's, it has to be the interest of every one of us, whether we have an insurance or we don't, because in the end, everybody is affected. What are the possible solutions? I always think of something to do. How do we fix it? How do we improve it? I always have ideas. The problem with us is that we have limited access to those who make decisions in powerful places. And I'll end by some personal thoughts. Hopefully try to make some sense of where we are and what we need to do. Those are my personal thoughts, but I thought they were important because they were, in my opinion, very helpful in my inner circle where I touch my patients, how I deal with them. Healthcare affects every one of us. Like it or not, you are either part of the system, using the system, whether you are born, whether you're pregnant, whether you are delivering somebody in the hospital sick, or outside taking care of a sick person. No one is escaping. And the fact of the matter is that we spend the most in the world per capita. We are about $10,000 per capita in this country compared to much lower in any other civilized nation. The United States, on top of that, when we spend this much, we lag behind many civilized nations in other quality, access to care, equity, and in life expectancy. So how would you like it if you invest so much in something and your return is so dismal? You'll feel discouraged. You'll feel that you're being ripped off. It is not appropriate. And then on top of that, not only that we have highest cost, lowest quality among the civilized nation, we have some people who are affected more than others. Those who are either not having insurance or they have low coverage by their insurance, we call them the underinsured, or they have different status, poor, immigrant, and other people in this nation. These are some of the facts. We are at 18% of our GDP in healthcare cost. In 2025, we'll be at 20%. We spend at $10,000 per capita. we are spending 3.2 trillion with a T, $3.2 trillion in healthcare cost. 150 billion in oncology cost in 2025, and some of you may have heard that latest drug that was approved, $650,000 for the treatment for one patient. And then on top of that, there are those who rip the system, estimated $272 billion in fraud and abuse. That can cover many, many people. This is how it's going. If you look at this chart, you can tell that we are at the top, not in quality. This is our GDP and expense. You can see it's rising, and no matter what we did, it keeps going up compared to the bunch of other civilized nations that you can see over there. So this is an old one, up until 2010, but as I mentioned, it's 18% at this time. This is how much it costs per day for a person in the United States, $12,500, and look at the other countries. It makes you wonder, what are we doing differently when we spend this much money? This is a comparison among many nations, civilized nations. We're not talking about Syria. We're not talking about Somalia. We're talking about civilized countries. The United States is number 11 in quality of care, in access to care, efficiency, equity, and healthy lives. We should not accept that. We need better. The Institute of Medicine suggested that we are not doing so well in preventing chronic diseases. We're not treating the causes of those chronic diseases. The poor lifestyle choices that we have in this country are leading to more asthma and more diabetes among our population. The other fact that we have extremely poor coordination among physicians. This is leading to more expensive workup, testing, care for patients, and this shouldn't be the case. In Europe, many years ago, it's a very simple solution. Every patient would carry a flash drive that has his or her medical record. And they go to the doctor, they put it in the computer, they put a password, and there we have all the information. Until today, a patient comes to me to the office from a neighboring hospital and asks them what was done. They have no clue. I call for the record. It doesn't come in a timely manner. I need to do testing. Should I repeat it? Should I order more testing? I am wasting money to take care of my patient. And this is 2017, the United States, the wealthiest country in the world. We could not agree until today on one electronic system that we can all use together so we can communicate better. Finally, we underuse high value and low cost services. And I look at this one and say, what is the highest value that is the lowest cost service that I can provide to my patients? I always said, well, listening to my patients, looking at my patients, and actually touching my patients. I can gather enough information to make a decision a lot faster. And on top of that, we tend to do too many unnecessary testing. We order a lot of lab that is not needed. And we cost so many in procedures that are not needed. We do more back surgeries than anywhere in the world. Unnecessary surgeries. And so many times I see the patients coming back with more pain and more misery and more disability. And at the end, I see them applying for disability. It is important for us to recognize the problem and try to fix it. Some of the drivers of healthcare costs, those are some of the facts. We're aging population. Our people are getting older. It's estimated by 2020 that we will have 64 million people over the age of 65. They need care. We are living longer. That will require more care for those help and assistance. The third-party system, this is a tricky part because remember, when somebody else is paying the bill, people may not pay attention to how much it costs. I mentioned earlier today about my mother who fell back in Syria and she needed hip surgery. My nephew was asking the surgeon what kind of hip replacement you're going to use, which one more expensive, should we use this one or that one. So we don't have this one. People don't know exactly how much it costs for them to do any procedure, any test. They come to the office, they go to the hospital blindly. They have no idea how much it costs, and some of them say, okay, doctor, do the most that you can do because somebody else is paying. I remember one of my patients who became eligible on Medicare, and that patient says, Doc, I have Medicare now. Could you order all the tests for me? I said, well, let me tell you something. You will get every needed test. You will not get every test. Because guess what? What you use and what you take from Medicare, if it's not necessary, is taken away from somebody else who needs it. It's one pie, and whatever more you take will be taken from somebody else. The fee-for-service is a problem. If I'm a doctor, every time I see a patient, I'll get paid. I'll see more patients, I get more. If I do a procedure, I get paid this much. I do 10 of them. So you put a dollar sign, people do more of it. And we need to find a different way in reimbursing healthcare. Not only by quantity, we need to recognize that quality of care is critically important. It's not how many you do, it's how well you do what you're doing. We're too late in doing that. Hopefully the new system will address this issue. Now, patient and family expectation is an issue that I spend enough time on to talk about. Because many times we don't understand what to expect. And I've seen this happen many times, that doctor says, well, what would you like me to do? And the answer would be, doctor, do everything. And you have to step back and say, well, let's think about it. If I have someone with metastatic cancer spread to the brain and the person is not eating, should we stop and think about what is the alternative to this, since we're not going to cure the patient? Can we discuss compassionate end of life? Can we do something differently? The difficulty that I see, that many doctors aren't trained well enough to discuss end of life. They don't know how to talk about it. They shy away from discussing the issue, and they tend to, okay, well, the family said this. I've never encountered any time in my life a family that was resistant to exploring the issue when said in the proper way. The new innovation, this is something that you see every day. There is an ad for something. A couple of days ago, a patient of mine who had some back problem came with a brochure of a device. He put it on the table. Very nice gentleman, patient of mine for a long time. And he said, doctor, they told me that if you write me a prescription for this, they would give it to me for free. And I immediately looked at him. We have a very nice, friendly relationship. He says, okay, John, no. He says, you're not going to give me a prescription? I said, I told you, no. He says, why? I said, there is no evidence that this device that you're asking about, that it does anything. It is no different from you going home and putting a heating pad or an ice pack on your back and doing some stretching exercises. That is free. So he accepted, but we need to spend some time and explain why not. I find doctors having difficulty finding the time to explain the why not. It's easier for any doctor to see the patient quickly, write a prescription. They will be happy when you tell them, oh, okay, you want an MRI? Here's an MRI. You want a scan? Let's do a scan. One of my patients who was in the hospital came to my office. He says, doctor, I like this doctor that covered for you at the hospital. I said, really? Tell me why. She says, every time I said something, I was downstairs doing a test. That's a waste. Nothing came out of all the testing that she did. I bet you if he listened and touched, could have done it a lot easier. Then we have novel drugs. We cannot escape those. There are many new drugs. Every day there is something new. Pharmaceutical companies are in the business of making new drugs. Some are wonderful, some iffy, but they market a lot. One of the drugs that they marketed is a combination of two old drugs. Two old drugs that are generics. They put them together and marketed them as a new novel drug, whatever, $450 a month. So we have to be careful. We have to be reasonable in what's appropriate and what's not. And then there are some solutions to this one. The government has to be more proactive in addressing the issue of high-cost drugs in many different ways. Malpractice and defensive medicine is a problem. Many doctors are so afraid of making a decision because of what may happen. And I hear that a lot. I say, okay, well, does your patient need a stress test? I say, well, there is a chance 1 in 1,000 that may happen. I don't want to give, but you said in your assessment that this is a muscle pain. You said it. Well, so why are you doing this test? Well, you never know. So there is that in my opinion, unfounded fear, because I didn't see that. I don't think that if I assessed well enough and I listened enough to my patients, made the right decision and documented well, that I should be too afraid. On top of that, people tell you if you have good relationship with your patients, explain well to them, they're more friendly to you. So we have to spend more time in evaluating the patient. I left that fraud, abuse, and waste, and you could see those folks sitting on the side sucking every ounce of money that Medicare or the nation's healthcare has. You could see that the chart is the livelihood of this country is going down by many people participating. I'll mention this story because when you practice appropriate medicine and you think that you don't think about fraud and abuse or something. You think people are human, ethical. One day my secretary came to me and says, Dr. Baghdan, the FBI are here asking for you. I said, oh my God, you don't want to hear that. I said, okay, send them in. So a very nice young man comes in. He had his badge. He says, you're Dr. Baghdan? I said, yes. What's going on? He says, is this your signature? I said, no. What is that? He says, this is an order for a wheelchair for one of your patients by somebody. The wheelchair was never delivered, but the bill came to Medicare to pay. It's $1 million business, and they're investigating that. So he just needed a sample of my signature. But you don't know that this exists. You don't think that somebody has the guts to do that if they don't have the ethics. And this is a lot more common than we think, and Medicare doesn't have enough personnel to investigate and chase all of those. They go after the big ones. When, something really large, 40 million, 50 million, they go after it. But the little ones, they go under the carpet. Other challenges for our healthcare, especially Medicare and Medicaid services, there is a mismatch between revenue and spending. We have more people aging, we have less people providing in taxes and revenue for Medicare. The benefit design is outdated, and the old system for fee-for-service is also not helping. The government made many interventions over the years. Well, since the inception of Medicare in 1965, they tried to cut costs either by putting a DRG in. For those who don't know, the DRG is a diagnosis-related group. If you come with a congestive heart failure, we'll pay you this much. I don't care how long the patient stay in the hospital, but then other doctors and hospitals probably find a different way. So if you pay a DRG, they come twice instead once. We get paid twice. There is then a Balanced Budget Act. Medicare says, okay, we're not going to spend more money. Here's how much money we have, and every time we spend more, we have to cut it from somewhere, which caused a problem because they cut across the board. And for the lowest part of we consider the primary care is at the bottom of the payment system, so that then across the board every year they come back and say, we're going to cut 20%, we're going to cut this much, and it didn't work. And recently they said, okay, we're going to abandon what they call the SGR, Sustainable Growth Rate, and move to a new system that they will pay them. Let's hope that this new payment system will work. Then they came up with the idea of the bundle payment, where they will give you this sum of money. You guys decide who gets what. If this is the cardiologist, the electrophysiologist, the primary care, whatever, this is how much we will pay you, and you divvy up that amount of money. And then the accountable care organization, another idea that came about, I think 2012 or 2013, where it says, okay, there is this much patient, that many patient that will belong to this organization, and we'll give you this much money. If you save money, we'll divide, call that the Medicare shared savings. So we'll pay you a certain amount of money, and if you save money compared to other part of the nation, you will get a portion of what you saved. Pay for performance is something that has been in the market for quite some time. A portion of your payment is tied up to a quality of care that you provide. It helps to a certain extent, but if you look at the chart, we've been doing the pay for performance for some years now. We did not bend the cost curve. We always found a way to make more money. And this MACRA is the new payment model that will be started in 2018, a new program that will get some measures on every physician or organization to put quality and efficiency. So we'll put them together and pay you accordingly. And it's supposedly a zero-sum gain, so the ones who do too well at the bottom will have to pay the ones who do better at the top. I reserve my judgment until we see the results, because we've been hurt over the years so many times that there was no good solution that we have seen so far. So I hope I see it in my lifetime. So we hope always for a rosy healthcare. This is what it should be. It should be peaceful. It should be friendly. It should be simple. Where we see on the other side, this is exactly what happens. I don't know, when we do a procedure or do a test, we get bills from all over the place. I don't know who this is, and I don't know. I mean, even us doctors, people ask me, I have no idea. I have no idea. We are part of what you see over there. So I'll echo what Bishop Perry said, healthcare is a human right. We cannot ignore the fact that these are human beings that need to be taken care of. And healthcare has to be appropriate, accessible, quality, and it has to be available to everyone. There is no way that somebody, my neighbor, doesn't have access and I feel good. I always say that there are two things in this life that you cannot have alone: health and happiness. You cannot be healthy by yourself and your family or neighbors or friends are not healthy. You cannot feel happy if your other friends or family or neighbors aren't happy. We are part of a community. We are part of humanity. When we do not have access to care and we do not provide equity in healthcare, we get some problems, especially affecting those at the lower end of the scale. Most of those are people of color or low income. Most of those are part of this disparities. They are more uninsured or underinsured. Even with the Accountable Care Act, Affordable Care Act, I still had some people who couldn't afford to come see me because their deductible are so high, their co-payment is so high. They have a card, says, doctor, I cannot come see you, I have to pay full payment. And I keep telling, look, I will put the lowest charge, just you need to come, just come, because you cannot ignore something and wait until a disaster happens. They get lack of access to care and they encounter the worst health outcome because they delay the care. They don't see the doctor. There was one case, I will mention this, that there was an undocumented immigrant who had abdominal pain. Yeah, he doesn't have access, he doesn't have any health coverage, so he waited until his appendix ruptured. And what happened after it ruptured? He had septic shock. And with septic shock, he had anoxic encephalopathy, which means no supply to the brain. So he had brain damage. He stayed in the hospital for over 170 days in the intensive care unit. Who took care of him? We did. All of us did. Because we did not cover that simple visit to the doctor in the beginning who can touch his belly and says, okay, we can do it for $1,000. We ended up paying millions of dollars and lost a person. He will never recover. Other contributing factors, we cannot ignore some individual factors. Those who have bad behaviors. They don't eat right, they don't exercise, they're obese, they smoke, they do drugs, alcohol, and all of that. Other provider biases. This is on us. We don't admit it. We don't say it out loud that we have our biases brought by culture, language, color, different things. We have to open it up and make sure when we look at a person, we look at a human, and that's how we should treat them. Linguistic barriers, we assume that if the patient doesn't know how to speak English, maybe they don't comprehend, maybe they're not smart. That's a barrier that's a bias on our part. So we have to recognize that and make some changes. Other environmental and social areas, the poverty, the lack of education, the proximity to area of care, and one of the important areas here in the city of Chicago is safety. We have high murder rate, we have unsafe places, and those areas do not have access to care. Who would want to open an office in an area that you can get shot? So we have to provide safety in those areas. Some of the facts about healthcare disparities: that people of color and low income face more barriers in receiving care. If you don't have good insurance, you don't have access, you're not going to get access to care. They receive less optimal care and less preventive care, including mammography, pap smear, colonoscopy, and other things, vaccinations. They are subject to poor outcome and high prevalence of asthma, diabetes, and cardiovascular disease for multiple reasons. Whether they live in a neighborhood where there is no access to good food or education, or poverty and different things. They have 8 to 10 times higher rate of HIV and AIDS. Black male have the shortest life expectancy among all. And black infants are twice as much likely to die compared to their white counterparts. 38% of us are of some color. So we have to recognize that this is not, we're not talking about the 1 or 2%, it's approaching 38%. 43% of rural counties do not have access to obstetric services. 43% of our rural counties. 50 million Americans lack access to primary care, and we still have 28.5 million Americans with no health insurance. 28.5 million. It's a country. It's a large country. So why do we care? I have insurance, right? So why should we care? Well, we care because if there is disparity and poor outcome, there is an effect to the entire population. No one escapes. We will all pay for it, like it or not. If you don't pay up front, you will pay at the end. If you don't treat hypertension, diabetes, you will end up with kidney failure, and when they have end-stage kidney disease on dialysis, guess what? Medicare will pick up the tab. So, pay the visit in the beginning, lower cost of drugs, make it affordable, treat those preventable conditions, save lives, and save money. 30% of total medical expenditure on Black, Hispanic, and Asian are due to health inequities. So that we need to address that. So this is, you can see 30% of that expenditure. We need to fix it. And then when we don't treat asthma patients or hypertension or diabetes, and they land in the emergency room and then get admitted, guess what? We have a higher bill. We have loss of productivity, and we lose on the economic side. And then finally, there is higher rate of premature death. People die sooner. There is a high prevalence of diabetes, as you can see, in Black and Mexican compared to others. Now we can talk about the social, familial, genetics, whatever, but there is definitely something over there that had to be addressed. Asthma, high prevalence in Black, and that has to do with early childhood. We didn't provide enough preventive services to avoid asthma. And then infant mortality, you can see that 11.3 compared in Black compared to much lower in most other ethnic groups. In discussing healthcare disparities, we cannot ignore the fact that income inequality plays a significant role in how and who receives health care. Poverty, lack of resources will lead to lack of insurance, and those who have more money will have better access, will have better outcome, and live longer compared to those poor people. 28.5 million people uninsured, and the majority of them are below the 400% of federal poverty line, meaning that about $80,000 income, but yet they don't have enough health insurance. It's expensive. And about half of them were white. Half of them are white. So, we can talk about race, but we cannot ignore the fact that poverty plays a significant role in who gets health insurance, who gets better care, access to care, and quality of care. Why didn't those people get health insurance? Half of them said, we couldn't afford it. We couldn't. That's simple math. I don't have $1,200 and $1,400 to pay every month. That's a big chunk of the money that I need. Patients tell me sometimes, doctor, I need to eat, which is true. But my priorities are this way. I need to eat, I need to pay my mortgage, whatever, then I will think about my health care. When people don't have health insurance, you can see they forego going to the doctor. 54% of them, they had no source of care, or postponed seeking care, or went without needed care due to cost. So one way or the other, there is something about the uninsured, even though on Medicaid, but at least they get something by Medicaid. They're uninsured, they're not getting care for something that is needed, or they're delaying the care. Sometimes they just take half, or I have patients with asthma, and they come back with some symptoms. Are you taking this inhaler? Tell me how you're taking the inhalers. Well, I'm taking that every other day. Well, you shouldn't do that every other day, doctor. It's so expensive. Well, that's not the right care. But when they tell me, look, it's so expensive, what can I say? If you look at on your right side, people are more likely to not get prescription drugs or dental care when they don't have coverage. So even when you prescribe the medicine, they cannot afford it, they don't get it. That means that they're not taking care of an important problem. Could be hypertension, diabetes, asthma, and other things. Now we're making progress, so if we have some hope that we see on the left side, this is mammography, and kudos to African American ladies. They're almost or surpassing others in getting mammography. So there is something hopeful on this one, that we're seeing some progress. Not enough, but that's a hopeful sign. On the right side, the colorectal screening is not there yet. And this is a simple test. You do it once every 10 years. It saves lives. If you do it, and you can avoid having a colon cancer, save your life. The government provided some initiatives over the years, whether this is the federal government or the local government. So this was in 2000, in the year 2000, there was the National Center for Minority Health and Health Disparities that provides some information, data, and solutions and stuff. In 2011, there was the Action Plan to Eliminate Racial and Ethnic Disparities. That's from the Department of Health and Human Services. In 2013, this CLASS Act, in abbreviation, which is for language barriers, that if someone comes to my office, for example, and then don't speak English, I have to provide interpretation. An interpreter has to come either by phone or in person to explain something, which provides some needed communication. And the most important one is in 2014, the Affordable Care Act, which provided some benefit to 13.8 million and added the college students to their family, and made sure that no one with a pre-existing condition would be denied care. So some of the hopeful ideas in the plan. Now you can argue my biggest problem, for example, that those underinsured, that they had something from the exchanges, but they couldn't come see the doctor anyway. It was for catastrophic. I wanted to go beyond the limits that it went, but this is what we've got, and now it's being challenged left and right. We don't know what will stay with most recent executive order that will remove subsidies. So Illinois, for example, will be hurt because that significant amount of money that goes to Medicaid, so to cover some people. So we'll see how that will go. Now we all want change. Everybody demand change. However, sometimes the change is not the right change that we want. Sometimes it's too little change. That gap between rich and poor has gotten extremely bigger. We have 0.1% of the population earn more than 6 million figure, compared to the lowest 90% who earn only about 34,000 a year. That's mind-boggling. And the trend is actually going higher. So we have the highest gap today. And I'm not against people making money. But we have to be realistic. You know, when you see the market going up and people, whatever, feeling happy, I ask my patients, well, are you feeling this wonderful return on that market? Says, what market? That doesn't affect me. So most people don't see that. They live in a different world. So what solutions are there? You know, the solution are on multiple levels: the government, the private sector, and others. The government should, in my opinion, those are opinions, by the way, the healthcare reform, including all participants, because it was painful to me to see that initiatives and solutions that affected only one section. You go after doctors, hospitals, or something, but then we forget that we need to include pharmaceuticals. We need to change the patent law so that drugs are available a lot faster than they should in generic forms. You have to change certain other innovations and how we provide them. I mean, there are so much. I call that the 360 healthcare reform. You cannot ignore any participant all the way across the board. The pay for performance, this is the new system that is happening next year. MACRA, Medicare Access and CHIP Reauthorization Act, which will measure quality and efficiency in a gradual manner over the next 5 years, and then reimburse doctors according to how well they do on both ends. So we'll see if that provides some solutions. The bundle payment, I mentioned that earlier, the accountable care organization. Transparency, I'm going to touch a little bit on transparency, and I mentioned earlier today that, well, my mother, how they negotiated, so people know exactly how much they need to pay. And St. Anthony, we have Jim here, who mentioned that his hospital, and there is that report that says they have good quality with efficiency. That's wonderful. This is what we need to explore so people can see that, and they make the educated decision. So they need to know, when I go see this doctor, how is this doctor's quality and efficiency? Is he good? Or I'm just going blindly, well, he is busy, he must be great. And I've had many doctors that I've seen, and I know their quality, they have the highest admissions to the hospital. Their quality is dismal. But, must be good. He is busy. We need to provide incentives and tax benefits to improve the economic inequality. And this is the government job, is to go to areas, the poorer areas, and provide incentives to companies to say, if you locate in that area, this is how much you will get in return, so you can hire and get those people to be more productive. When one time I was watching an interview with Tim Cook, Apple, and they asked him the question, why do you go to China? Don't we have people here? Why do you go to China? He says, well, we don't have enough skilled labor. Well, that's a shame. That is a shame on us, that we cannot provide enough incentives and tax relief for people to invest in these communities. We have plenty of space, plenty of people, but we don't invest in them. Student loan forgiveness for underserved areas. Now, I would encourage this one. If you are a person who comes from an underserved area and you study to become a doctor, a dentist, a pharmacist or something, and you locate in that community that you came from, you should be forgiven. That's an incentive that we should provide. Fair reimbursement for primary care. Of course, I'm biased. I am a primary care physician, and as we move, I am spending more time in a lot of red tapes and measures and different things. And if I need to take the burden, we are reimbursed at the lowest. And over the years, the reimbursement is geared toward more super specialties. They pay more for them. And one of my friend cardiologists who used to see a patient, and he took care of her heart, and the minute she started asking a bunch of questions, my knee hurt, my whatever, he said, okay, go see Dr. Baghdan. She says, you've been my doctor for a long time. He says, look, I am the doctor from here to here. Go see Dr. Baghdan for everything else. So we try to take care of everything, and it's getting really, really overwhelming, and to spend enough time, I think we have to revisit the reimbursement for primary care. Tort reform. People argue that tort reform, by the way, for those who don't know, it's malpractice. Malpractice is extremely high for doctors, especially in the state of Illinois, compared to Indiana and Wisconsin. So it's neighboring state. Some of my friends moved, relocated, and some of them, by the way, will take the patient from Illinois and do the surgery in Indiana, because Illinois is not friendly. So we pay 3 times higher in Illinois compared to Indiana in malpractice. So on one end, it's a burden. On the other end, it's making some doctors practice under fear. That, okay, you know what, I don't want to be blamed or something. Let me do everything. Let me send my patients to see 100 doctors and do everything possible. The private sector, I've seen some encouraging signs in some of the companies, some of the private sectors that are asking their patients to go to see the doctor. They will give them some benefit on their premiums and stuff. So they come to the office, they do their A1C, the lipid panel, I measure their waist or something. Some companies are providing clinics in their large companies, and that's a great idea, because this way I am working at this company, I need to see the doctor, I go downstairs, check with whatever, and do my visit quickly. Fitness, free fitness plan, wellness plan, different things. So the private sector, healthier workers are more productive. So I think the return on their investment is quite good. I like the education part, and education has to be to everyone involved. I touch 2 groups of people. Those are my patients and the doctors I work with. And I try my best to provide enough education to explain the why and what and when and why do we do what we do. I try to talk a lot with my patients about healthy living, promote diet and exercise and weight loss, preventive tests. I am very strong at that one. Sometimes, some of them do it just to please me, so I get off their back. Did you do your colonoscopy? Did you take your flu vaccine? So I encourage disease prevention. I explain fully the risk of untreated. I always try to paint a picture of what can happen if you do not treat your hypertension or diabetes, because they don't see it 10 years down the road. This is what I see. And I tell them, look, the reason you're doing this is because you live today, and I am doing this because I don't want you to be in this picture 10 years down the road. I provide transparency on cost, and we need to provide transparency on cost and quality. We touched on that one before. I promote quality of life, not quantity. People don't want to live too long when there is no quality of life, so we need to discuss that quite well. And proper use of resources. People don't know how much it costs to go visit the emergency room when you don't need to. You go there for every little thing, and cough and cold and whatever. The visit to the emergency room is 10 times, at least 10 times, more expensive than coming to my office. But some of them go to the emergency room because they don't have access. You know, we go back that vicious cycle. They don't have access. The doctor won't see them. They wait until it's too long, and then they go to the emergency room. So the ones that I see and touch, I try to make it very clear that emergency room is for emergencies. Try to explain it in a way that they understand it. The provider education is very important, because if we do not change the behavior of our providers, because we used to carry the pen, now on the computer, we write orders, we tell them what to do. If we do not do better on this community, we're not going to save healthcare. We need to have a proper vetting for those applicants. Those who want to go and become doctors in the future, we need to know exactly why. I would like to emphasize on the mission before the profession. My job, first and foremost, is a mission. If it's for the money, I could have done better doing any other business. Because the time that we spend preparing and getting there, and the time that we spend in taking care of patients, may not be a good return on the investment for some specialties. So we need to emphasize that this is a mission. We will get enough money, don't get me wrong, we're good. So we need to understand that we do well, but we can do better on the mission part. Timely access of care. If I don't open my door for my patient who need to come see me immediately, and somebody answers the phone and says, okay, come see the doctor in 2 weeks, but I hurt now, they go to the emergency room, so we're wasting resources. We need to focus on the quality and not the quantity, not how many patients I see, it's how well I do the job. I need to educate my fellow physicians and make sure they understand the disparities and inequality in healthcare. We need to raise the awareness among doctors so they can provide some helpful support. Promote the value, and what I mean by that, doing more is not always better. It doesn't matter how much you spend. There are actually studies that showed that more expensive testing workup did not provide better quality of care. It is how well and how accurate in what we need to do. And we need to define success. What is success to me? Is it how much money I make? Or what is the positive outcome of my service? Did I serve my community well? Did I achieve a good quality of care? Did I make a positive impact in the community I serve? We need to bring back to our doctors the importance of defining their success. They're not there just to get the bill. We need to manage peer pressure because many doctors look at other doctors in their specialties and this doctor is making $1 million. I must be doing something wrong. Actually, my wife tells me sometimes, is that your friend? I say, yes. He does exactly what you do. I say, yes. I say, well, look what they have. My success is defined a bit differently. I couldn't go see a patient in a couple of minutes and move them so I can see the second patient. I need to make sure that my patient was well served. Thank you very much. Appreciate it. That's a wonderful service. There are some appropriate health expectation. I talk about this a lot. What is care versus cure? Many times I tell my patients, look, there is no cure for this, but we certainly will care for you. So the care has to be appropriate to the situation. So you cannot cure everything. We're not going to be gods. We have to admit our limitations. When we cannot do it, let's work on the care. Sometimes you need something, you get it done, but don't be greedy. There are those who think, I paid into the system, I should get everything done. I should get my MRIs, my scans, my testing, whether it's needed or not. And I try to tell my people that I promise you, you will get what you need. I don't care where, but I'll get it. I don't care what your insurance you have. If you need it, I'll make sure you get it. But if it's not appropriate, I'm not going to allow it. I'm not going to allow it. I had a friend actually brought her son to my office not long ago, and she says, it's always difficult when you have somebody who knows you. She says, could you do all the tests for my son? I examined her son. He's healthy, 18 years old. I says, he's healthy. She says, but I'd like to make sure. I said, I am sure. Don't you trust me? She says, yeah, I trust you, but I'd like to make sure. I mean, it took a little time of argument, and then I said, I'm not going to do it. It is not needed. We have to get confidence that when it's not necessary, let's not get greedy. Thorough versus wasteful. I mentioned my patient who was doing every test. Every time, you ask, one person thinks that this is a thorough doctor. He does everything. And sometimes I look at it, that's wasteful. That's wasteful. I had a patient, an elderly lady who comes to me. It's been my patient for 20 years. Every year she comes to me with 2 reports. She says, doctor, here's my echo and my stress test, my annual echo and stress test. I said, who did that? She says, my cardiologist. For what? She says, I don't know. They called me and told me it's time for your annual echo and stress test. I said, look, I've known you for 20 years. You have hypertension like my mother. Ask me how many times my mother had an echo. She says, how many? I said, none. She's my mother. She never needed an echo, and you don't need it either. I'd like you to go to your cardiologist and ask them, do I need these tests? Are they really important? And guess what? They stopped coming back. They don't do them anymore. It's not necessary, so that is wasteful. Compassionate end-of-life discussion versus death panel. You've heard this discussion before. Oh, you cannot talk about end of life, but we should. We should bring it to a level that is very compassionate. Tell people that death is part of our life. No one will live forever. When the time comes, I tell them, please stop fighting God. It is time that we need to let go. We spend so much at the end of life, but when we do that, we're denying many others who needed those resources. So we need to bring that discussion, talk about it. Rationale versus rationing. Doctors need to be rational so we don't ration medicine in the future. I tell folks in this country that you are so lucky. You have everything you need. But be careful. This may not last, because you cannot keep doing what you're doing, waste money. The time will come that you probably won't have it. I'll give an example of how it happened back in the old country. I was second year resident in the intensive care unit with 3 other doctors. It was a busy night, must be a full moon. We had about 50 admissions that night. We had patients in the hallway, and for those who don't know other countries, there is no, we're on bypass or something. So you cannot close. You cannot call an ambulance to transfer somewhere else. There's nothing. It's who comes to your door, you have to take care of them. And at that night, every ventilator we had was used. Every one of them. And I was praying not to get any more patients who needed a ventilator. And sure enough, we get a young lady in her 30s who had accidental pesticide poisoning. She was drowning with her secretions. Now there is no, so you have to intubate her. So we did. Now we have no ventilator. And we're looking around. Now we're trying to find out who is the least person to make it among those who are on the ventilator. So you have to pick one and have to remove life support from that one so we can save her. I hope we don't get to see this in this country, but we have to be careful. We have to be rational. We have to pay attention to quality rather than how much more we can do and how much money we can receive. Some of the promising support that we get today, that we have community servers, workers, extenders, midwives, artificial intelligence. You know, my wife is big on information technology, and this is the future. So we may get some help from that. Telemedicine is a good one, that people can be at their home, since we cannot do house calls anymore. Those are wonderful time. I used to enjoy them. You know, people, bring you coffee, sit down and talk and have a good conversation. And virtual house calls. So some of the possible solutions that could be cheaper if we can implement them well enough. What are my keys to success? There's something that I felt that if you do that, you will do well. If not in the larger community, but you probably do it among those who you can touch, because that's the biggest impact on those around us. So treat people with respect without bias or prejudice. You look at people as human beings and treat them as well as you want your family to be treated. You need to look, listen, and feel. That's the cheapest way to make a good diagnosis. 90% of the diagnoses I made were done after I finished talking to the patient. I rarely get a shocking surprise with the test I did. I have a hunch. So if we put enough effort in listening to people, we'll do fine. Show your human side. People would like to know that you're human. You're not someone sitting in a box somewhere coming from Mars. You are as human as they are. They need to know that, so they listen to you. They know that you're credible. You know what you mean what you say, and you are true to what you say. Do not rush patients. This is something, I'm always late on my other patient, and I explain it, and they tell me, "Doctor, don't worry. We know when you sit with us, you never rushed us." They need to explain everything. They need to ask all the questions before they leave. make sure that you have enough time for them to say whatever they want. And you can look at the patient and see if they received it or not, and you can follow up. Answer all the questions. It is okay to say, I don't know. I think the longer you practice, the more humble you become. And you can say, and I say it today, that I really don't know. It's easier than to make up stuff and try to look smart when you don't know what you're talking about. So I say one thing, it's either I know it or I know who knows it. So, I'm very clear on that. Explore hidden motives and interests. People don't come always with a clear-cut problem. You need to know what's behind it. Is there something going on at home? Is there something else going on in the workplace? So you need to be able to get some cues from the patient. Partner with patients. I tell my patients that I'm an advisor, I give you my advice, and we are partners. If you succeed, I succeed. We cannot be at odds with each other. You'll feel good, I feel good. You feel bad, I'll feel bad. And the opposite is true. So it's either we make it together or we fail together. So they know that. Practice what you preach. I would never tell my patient not to smoke and I go light a cigarette. I cannot tell them you need to go exercise and I am not doing that. Actually, some of my patients ask me, tell me what you do. Says, okay, they just get back at me and says, okay, tell me what you do. Okay, and I tell them what I do. And clearly define expectations. So before they leave, they know exactly what I expect. I'm not going to give people empty promises. If it's not going to be cured, I'm going to tell them, I'm sorry to tell you, this is not going to be cured. You may have some pain for a long time. So they don't get shocked with some problems down the road. So I hope by the end of this conversation I didn't make many people depressed, because sometimes I felt that way. The issue is extremely difficult, the subject is hard, and we're facing extreme challenges. And in all honesty, at this moment, outside of people, wonderful people like you and others who are working, trying to explore the subject, trying to make some positive changes, I don't see that the nation is yet going or moving in the right direction. And I am hopeful that the light that we see is not the near-death light, it's actually the light at the end of the tunnel. I wish you luck, and I appreciate having me here to talk with you.